Hi everyone, and welcome to the fifth TIA Centre seminar of the academic year, and the last one before the Christmas break. So my name is Adam Shepherd, and I'm a postdoc here at the TIA Centre. And for those of you that are new to our seminars, we invite researchers and leaders in the area of computational pathology to discuss their work at our seminars. And today I'm delighted to introduce Hanwen Xu. Hanwen Xu is a third-year PhD student at the University of Washington. His research interest is mainly on AI for medicine, with a specific aim at multimodal learning for cancer research. He is also interested in developing useful models and tools with clear clinical use cases. His publications include articles at top journals and conferences, such as Nature and Nature Communications. And the title of Hanwen's talk today is Towards Learning Patient-Level Representations, Better Clinical Outcome. So thanks again, Hanwen, for joining us. And please feel free to get started when you're ready.
Yeah, so thanks for the great introduction. So thank you for having me here. So today I'll be sharing our recent work on building histopathological foundation model. So today I will try to begin with a broader perspective, like how we learn the patient level representations by integrating different or diverse kinds of image modalities that can unlock valuable insights and potentially offer the better clinical outcomes. So maybe let's start with the anonymized real-world patient case. So I like this case actually. So this patient was diagnosed with breast cancer almost 10 years ago in 2011. So during that time, she underwent the mastectomy to remove the tumor cancer, primary tumor cancer, as you can see highlighted in red here. So after this diagnosis, after the mastectomy, she managed without major issues for nearly a decade. But in 2020, she underwent severe back pain and then sought for the medical evaluations. And from the medical evaluation, unfortunately, this time, the tumors has been spread to her liver, her bone, and her brain. So the metastasis is almost everywhere. So then gamma knife was involved to address the brain metastasis first because she had very severe headache. And also the pathological examination also confirmed that this new cancer is indeed a metastasis from a cancer almost 10 years ago by checking the morphological features because it looks pretty similar. And after that, over the following months, this patient underwent a lot of therapies, actually almost exhausted every kinds of treatment options like the immunotherapy, targeted therapy, and chemotherapy. But unfortunately, the tumor on her liver still continued to progress. So this led to her case being brought in front of the tumor board meeting for more comprehensive discussion on the treatment plan. So after her case was presented to the tumor board meeting, the molecular testing results became pretty pivotal, as these molecular testing results will guide the clinician in decision making, aligning with the discussion either within the tumor board or the recommendation from the NCCN guideline following to identify a more appropriate treatment approach for this patient. So just this case to kind of illustrating how complex it is for a 10-year cancer patient journey. So you can see that during this journey, lots of medical data generated and it's multi-modal. It's very complicated. So this kind of highlighting the need for computational approach to learn a comprehensive representation for the whole patient over the 10 years. So this kind of like a multi-model modeling approach is actually a similar idea is making waves in the general domain. So great example, as we all know here, is a GPT-4 model. It can almost take every kind of modality as input, including images, vision, audio, and it can also generate everything from the text to image and text to images, or even hold real-time conversations. So this got us thinking, what if we just simply take the idea of the GPT-4 model and apply it to the healthcare domain? And then can we build a multi-model foundation model in medical domain that can take different kinds of input like CT images, histopathology images, genomic information, clinical notes as input, And then this foundation model can learn comprehensive embeddings, and this embeddings can help us to make more informed or better clinical decisions. So we call this model is a patient level model or patient representation learning model. But actually this answer, as I think we may have the answer. It's not a straightforward yes, because there's a lot of challenges associated with training a medical GPT model. It's not simply re-engineering of the GPT-4 model. There are at least three major challenges. So first, I would like to say that unlike a GPT-4 model, which almost exhausts every kind of data from the internet, which can add up to trillions of tokens, but here in medical domain, we cannot rely on the resources from the internet. Also, the data sharing due to the privacy concerns or PHI issue, data sharing between different hospitals or centers are usually restricted. And also because of the sensitivity of the patient data, the collaborations and data sharing become pretty challenging. So this kind of like hindering the progress for us to build a really diverse and large scale data set that is enough for us to train a foundation model in medical domain. The second challenge is that if we consider the data volume for each patient, like considering all the associated data we generated over the long cancer patient journey, it can potentially add up to a very long sequence, and that long sequence actually far exceeds to the length of the GPT-4 model can handle. So let's start by thinking about the patient case I have shown before. So for this patient, she have hundreds of CT volumes, as there is a routine CT check over the 10 years, and also dozens of host line images, and also hundreds of clinical notes. So if we add up everything together, then it will be millions of tokens. So those are actually too heavy for the GPT-4 model to handle. Um, and also, like for a single data modality, actually because of the long sequence problem, the hierarchical structures are intrinsically hard to be captured by a single model. So let's specifically focus on the pathological case. So here is one pathology host line image. It's a 3 centimeter by 3 centimeter with 40 times magnification level. So this image actually contains billions of tokens or billions of pixels. If we follow the traditional way of the vision transformer to model this gigapixel level image, let's start by looking at the table. So this table basically summarizes how the memory cost changes as we vary the size of a token, specifically the number of pixels each token represent. So as we can see that even we use a very large token, which is pretty uncommon in the general domain, for example, let's say the 256 by 256 or even 1024 by 1024, then the memory cost for storing the attention matrix is still very large. So if we considering that we are training a modern vision transform model with billions of parameters, then the memory cost far exceeds what the current high-end GPU like A100 can handle. So this problem is very severe. And another problem associated with the high sequence, the long sequence problem is actually the hierarchical structure of the host line images. So if we look at the host line images, it consists of different levels. So, and also depending on which task we are going to handle, like for example, the treatment response. So for treatment response, the key problem here is that we probably need to look at how the lymph nodes are distributed between the boundaries of the tumors. So to do that, the model needs to know which part is tumors and which part is the normal tissues and which cells are lymphocytes and how they are distributed. So to do so, you cannot just by simply looking at a small tile, small region of the host line images. The model needs to look at everything, almost every region of the host line images to make more accurate predictions. So in this case, we need a slide level model to do this kind of modeling. Another approach is like another perspective is the region level features. So this relevant task is the invasion patterns or the metastasis pattern identification. So in this case, for example, we need to know how the cancer cells are spread into the adjacent structures. So then the region level features came in, and also for certain tasks like the subtyping task, the tail level features becomes more relevant as those tasks, for some of the subtyping tasks highly depend on the subtle differences at the morphological level. So in those cases, we needed to go into the fine-grained details to check the differences between different tails, and then we can get informed by which cancer type this host lab images represent. The third challenges associated towards the patient level embedding model is that the paired data or paired modalities are actually very rare in the medical domain compared to the general domain. So the algorithm we developed in the general domain, like the clip alignment or the image to text or the vision language model, can hardly apply. So actually, one case is that even for the well-curated public resources like TCG data, we know that it's well organized, and there's actually lots of data modalities, but many of them are actually missing. So if we check the table here, so here, each row represent one patient, and each column represent one modalities, and we can see that for each patient, it usually contains a subset of the potential modalities. So this can be due to a couple of reasons. So it can be the financial constraint for this patient. For example, due to the financial constraint, the patient cannot undergo the genomic sequencing. But it can also be due to other reasons like maybe the data management issue or the linking problem across different data sources. So this makes us like if we check these tables, actually lots of modalities are missing for different patients. So this makes us thinking that can we have a better algorithm that can sort of like aligning patients more efficiently without requiring each patient to have all the modalities available. So here we propose our approach. GigaPath. So here we start from looking at the pathological case, and we call this model a host lab foundation model for digital pathology from real-world data. But this model is also generalizable. We can extend the model to different kinds of modalities, and also all the giga level pixel images in the medical domain, like the not just only the host lab image, but also the 3D data, like the CT images, the OCT data. So to summarize, the GigaPath, it consists of the following three strategies to tackle the previous challenges we have discussed before. So first, we have a multi-center collaboration with the Providence Health Network, and we collected the real-world cancer patient data from 28 hospitals under the Providence Health Network from nearly 30,000 patients. And these 30,000 patients have almost every image modalities like the CT, the histopathology, genomics annotation, and also other clinical annotations. So this large-scale diverse data is enough for us, almost enough for us to train a large-scale foundation model that can be really good at lots of downstream tasks. And also for the long sequence problem we have talked before, here we propose a general two-stage architecture to handle the long sequence modeling problem. So we propose a novel two-stage architecture. This consists of a local feature extractor and also a global representation learner. For the local feature extractor, it usually focuses on the tail level features of subtle morphological differences. And for the slide level global representation learner, it will aggregate or summarize more patterns from broader perspective on the host line images. And also specifically here, to extend the model to handle extremely long sequences, we use the LongNet model with domain-specific adaptations. And this LongNet model can handle actually billions of tokens. And this makes our model can be directly applied to the host line images and potentially in the future to model all the medical data associated with a single patient. And also for the rareness of the paired data in the medical domain, we also propose a multilingual translation system. And here in GigaPath specifically, it's like we translate the medical images into the text. But if we consider more general setting, like for each single patient, we try to translate all the medical modalities into the text, and then we use text as the bridge to link all the data we have. So this does not require us to have the paired data between all the modalities, but only requires we have compare the data between the image modalities and the text.
Sorry,
So
Hanwen,
here,
can I ask a quick question here?
uh-huh.
So for those of us that aren't familiar with long net, can you just quickly explain to us what it is? So how it goes from domain specific adaptations to getting multiple different. Yeah, can you just explain, sorry, what it's actually doing?
Yeah. So I'll be talking about the details
Okay, yeah, of
later.
course.
Oh yeah, I have a specific slides here. Yeah, so maybe
Thank you.
quickly give an overview of the model. So this model consists of a tail encoder. The tail encoder is basically a data model. It's a traditional vision transformer. It's a VIT-gent model consisting of billions of parameters, and we train the tail encoder on 1.3 billion image tails. So this is the tail encoder. The main aim here is to compress the local patches into dense embeddings. As we talked before, it's a local feature extractor. So after the tail encoder, then the slide encoder comes in. The slide encoder is basically a long net model. So here, the adaptation here mainly refers that the traditional long net model is on the maybe the image pixel level, but here the input is actually the image embeddings, which is already converted by our tail encoder. Then the image embeddings comes in. So if we think of, so each embedding here is actually one embedding from one tile. And if we look at the figure A here, so we overlay the grid onto the host line images. So that's sort of like tokenizing the host line images. So after this tokenizing process, we can serialize the host line images into a sequence of image tiles. So this sequence can be pretty long. And after converting each tile into the embeddings, then we have a sequence of embeddings. So that is the input to the slide encoder of the long net model. So here we implemented the slide encoder with the long-term model, and we try to pre-train on large-scale data, let's say 100,000 and 117,000 host line images. So this pre-training help us alleviate the overfitting problem we often encounter in the pathological domain. So for the pre-training objective, I will quickly go over this. We use the Dano plus the reconstruction on the slide encoder. So for the Dano pre-training objective is basically a student teachers distillation network. The idea is pretty simple. So given one image, we do the multi-cropping. We crop the image into global crops and the local crops. And for the teacher model, it only takes the global crop as input. So you can see that a teacher model has more information or broader information. So it's at a global level. But for the student model, we input both the local crops and the global crops. So the student model can potentially only have partial of the information. So that's why we call it a student. Then the pre-training objective is basically minimizing the loss or the discrepancy between the teacher model and student model. And for the slide encoder, we use the reconstruction loss, which is basically we mask out certain patches on the whole slide image, and then we force the model to learn to reconstruct the missing patches. So this is like forcing the model to have a basic context, have basic understanding of the context of the whole slide images. So after we having the pre-training objective, now we'll be talking about how the long-term model works in these cases. So yeah, so feel free to propose any questions here because I think maybe this is the biggest innovation in our work.
Yes, sorry.
Um,
Can I ask
yeah,
a quick question on the previous slide, please?
yeah,
Yes. So on the reconstruct masked patches, right? Did you,
right.
so just to clear for myself, did you compare the patch tokens out of transformers? Like, did you compare them, or did you reconstructed images literally based on
Oh
the
yeah.
output, embeddings, and then compare those two?
Yeah. That's a great question. So here actually two things. So the construction loss is basically both in Dano and also in Dano, which is the tile encoder pre-training, and also in the slide level encoder pre-training. So if it's in the tile level encoder pre-training, because it's already function in the pixel space. So this is actually on reconstructing the raw image pixels. But if it's pre-training the slide level encoder, we actually we already project everything into the embedding space. So this is like to reconstruct the missing embeddings. So and also the loss is a little bit different. For the patch level or for the pixel level reconstruction, it's more like cross entropy. But if it's in the embedding space, we are using a cosine similarity to minimize the discrepancy between the reconstructed embeddings and the ground truth embeddings.
Great, thank you.
Okay. Okay, cool. Yeah. So for the long-term model, I'll be talking about the dilated attention. We think it's a pretty beautiful algorithm here to sort of like canceling out the quadratic memory growth associated with the traditional vision transformer. So probably let's start with a very simple case. So let's say if we have a sequence length, a sequence with length as n, and if we increase the sequence length from n to 2n, then the memory cost will increase 4 times because of the quadratic memory growth. But that is not actually not what we want, because if it's in the histopathology and we have billions of tokens, then the memory cost will be pretty heavy and it will blow up our vision transformer. So we introduce the dilated attention here. So what is dilated attention here? So let's maybe think about we introduce a little bit dilated ratio. So for example, when we compute the attention score, let's say the first token, when we calculate the tension, the first token only attends to token 3, token 5, token 7 until the token 2n minus 1. So then the memory cost still remains the same because the effective loss of the dilated attention is around the same as what we got when we only have n tokens. So that is how we sort of like alleviating the long sequence problem. But there's actually a problem associated with the dilated attention. The biggest problem is that if we introduce the dilated ratio, for example, token 1 only attends to every other tokens, then the tokens the information in the token 2, token 4, or token 2n will be ignored. That's not what we want, especially for certain tasks in pathology. Probably we need to check subtle morphological differences, and this dilated attention can easily ignore some important information for the downstream tasks, and that's not what we want. So the beauty of the long-term model is actually that before we do the dilated attention, we first segment the long sequence into several segments or several fragments. And within each segment, we still perform dense attention because each segment is pretty short. So there will not be we don't encounter any severe long sequence problem here. So for example, in the figure we show here, we segment the image tile sequence into at different scales. Let's say starting from the 512, 1024, and 2048. And we try to increase the segment length, but in the same time, we also add in the dilated ratio here. So the beauty of the algorithm here is that actually, if we already perform the dense attention within each segment, then across different segments, if we still perform the dilated attention, for example, let's say the first fragment and the third fragment and the fifth fragment, if we still perform the dilated attention, we don't need actually to calculate attention to every tokens, because within each segment, one token have already represent all the information within that segment. So that makes us freely increase the dilated ratio. So for example here, if the attention pattern is pattern is shown here, the segment is 512 and the dilated ratio is still 1. So there is not long sequence problem. If we increase the dilated ratio, if we increase the segment length to 1024, then we increase the dilated ratio to 2. So within each segment, we can see that the effective length is still around the same. And also, this cancel out the quadratic memory growth. And if we keep going, we can actually increase the segment to very long until the whole length of the length of the whole sequence. And then we still keep the growth speed of the dilated ratio. As you can see, like from 1 to 2 to 4, or even to the n to 2. So after we do this, we can actually this long-term model can actually capture features at different scales while canceling out the quadratic memory cost growth. And after we have performed all the attention patterns, we then do a weighted average to obtain the final attention patterns, like we illustrated here. So different colors represent different segments we did before, and then this model can be applied to billions of tokens to aggregate or to summarize all the features associated with the specific host line images. So I think maybe we can stop here a little bit and see if our friends have any question here.
Yes, I have a question, if I may ask.
Yeah.
Sorry, I'm part of my ignorance, but I was just wanted if you can elaborate a little bit on segments and what this is like. We have 5, 12, 10, 24, and 2, 20, 48, right? So we know
Yeah,
the
yeah.
input here is not image patches anymore. So these are the embedding of image patches, if I'm not
Right.
right. So you have a sequence of embeddings.
Right, exactly.
What are these segments? Are these like segments in the sequence or in the feature space?
Yeah, so the segments is definitely in the sequence space because we are trying to handle the long sequence problem, right? So
Yeah,
if it's for the image embeddings as input, we can think of it as a tensor. The tensor shape is maybe n by l by d. So
yeah,
n is batch size, l is the length of the sequence, and d is the size of the dimension of the embedding. So
yeah,
the segment means that we truncate the l dimension, the length, into different segments. So
yes,
512 to 24, and also maybe longer.
yeah,
So after we did the segment, then we introduced the dilated ratio, and and for each segment we still remain the same effective sequence length. So if it's 512, then the effective sequence length is still 512. If it's 224, then we increase the dilated ratio a little bit, so the effective length is still 512. So then we get rid of the long sequence problem associated with the traditional vision transformer because the effective length is still 512 for almost every calculation inside the long net model.
Okay. So yeah, I got that. All right, that's good.
Yeah.
Thank you. So my other question would be, why did you, I mean, you explained it, but it's not still clear to me. Why did you
Mhm.
use larger, you
Right.
know, yes. Um,
So you mean larger segment or larger
no, no,
model?
no. No, what I mean, oh God, larger R, right?
Oh,
The
larger dilated ratio. Yeah,
Yeah,
yeah, yeah.
dilation. Why did you
Yeah,
use
yeah,
larger dilation with larger segments? Wouldn't it be, I mean, to me, if I understand the concept right, I would have assumed that
yeah.
because you have larger segments and you want to, you want to find attention between these two large segments, you
Yeah.
want to find the attention of the closed one, so you don't want to increase the dilation. Or did I get something wrong?
Yeah, so basically, actually, first, for the tokens close to each other, we don't want to lose that kind of interaction, but we argue that those integrations has already been learned in the smaller segments, let's say the 512.
Yeah, true. Yeah.
Yeah, they already learned that. So we don't need to still perform the dense attention as we increase the length of the segment. Otherwise, we still encounter the long sequence problem because if you increase the segment, it's still dense attention. Then the memory cost still grows. So that's
Mm-hmm.
not what we want here. What we want is actually that for the local features or for the local interactions, it's already learned by the very small segments. And in the very small segments, we don't have very severe memory cost problem. But for the longer segment, we think of it like the long segment is capturing more global features. And for the local features, we don't need to do the recalculation. So that's
Mm-hmm.
sort of like how we save the memory cost here.
It makes sense. Yeah.
Yeah.
Does make sense. It would have been nice if the other way was also investigated, right? I know you did it like this because it was memory, that was
Mm-hmm.
your main concern,
Yeah.
but you can, someone can also hypothesize it like this, that two small neighboring patches, they
Mm-hmm.
most probably have similar kind of patterns,
Mm-hmm.
whereas when the distance between them is more, then there might you want to capture the, interconnection between these two different patches. But I did
Yeah,
get
yeah,
what you meant here.
yeah.
Yeah, it's really smart.
Right. So yeah, this is a good point. So actually this highly depend on the downstream tasks, right? So if the downstream task is purely some like the subtyping task, then maybe some tail level features is enough for us to make the predictions. So in that case, probably we don't need the like the longer segments. We only need the local segments to capture the local interactions, and that is enough. But for other tasks, maybe the like the mutation prediction or the survival predictions and potentially treatment response prediction, we need more global features to make these predictions. And if we think of like actually for the host line images, actually there can be lots of redundancy because if it's a biopsy, the shape can be like some line shape, and then if you still perform the dense attention and you remove the long sequence, you remove the long net architecture, then it almost still like a calculated tension between every possible tokens. Then I would argue that maybe the blank area would take majority power of this model, and that will likely lead the model to fall. So that's another kind of consideration why we use the long net model here, because you can see that it's kind of like having very clear or very accurate calculation at the local level, but it's sort of like approximating the global attention calculation. So this actually aligns well with the nature of the problem we are going to tackle, because the host line image is actually a hierarchical structure, and we require modeling at different scales. So then this long net, if you think about the attention pattern, it's also like a hierarchical thing, right? So from the very low level, we have the dense attention, very accurate, and if we increase to the global level, we focus more on the global information while ignoring the local patterns.
Yeah, all makes sense. Yeah, thank you.
Yeah, thank you. So any other question? Okay.
No, I think we're good. Thank you.
Yeah, cool. So maybe let's proceed with this. Right. So after we have the pre-training objective and also the model architecture, then we start our large-scale pre-training. So this is sort of like the overview of the whole project or the whole mission. So we collected the data from 30,000 patients under the Providence Health Network, which consists of 170K host line images and 1.3 billion image tiles. And those data also has very rich clinical annotations from the clinicians, including the basically the histological type, genomics information, and also survivalorships. So after we have this, because this is a pretty large scale data, so we make use of the infrastructure in Microsoft. We use Databricks to perform the data pre-processing in parallel. And after that, we can, due to the multi-modal feature of this dataset, we establish a wide range of downstream tasks, including the subtyping, mutation prediction, surveillance analysis, and vision language pre-training. So I'll be talking about those tasks next. So in this slide, basically summarizing the performance of our model compared to
Sorry,
other.
Hanwen. Do you mind if I just
Yeah.
ask a quick question on the last slide? I don't know if you know into any more details about Databricks, but is it so? This is a pre-processing pipeline, is it? And does it also do some form of quality control, or?
Yeah, so for the Databricks, it's actually a platform. It's just it's like an infrastructure, has distributed clusters. So that enables us to pre-process the data in parallel. So
Okay.
that can make that, yeah, makes the speed much faster. Yeah.
Yeah, and I'm also wondering, so with the sort of the scale of the data that you've got here, so 170,000 slides, how do you go about actually doing some sort of quality control on these images or these slides?
Yeah, that's a good question. So actually for the 170K slides, that's not always about the primary cancer, because in the real world, the whole slide images can also be on maybe it's on the lymph nodes or on other parts of the body, probably not the primary cancer. But actually for the pre-training, we can use all the data we have. We can use all the noisy data, but it's still large scale, and that is probably okay for the pre-training stage, because like if we think about the GPT model, the pre-training, the first stage pre-training is also on the large scale noisy data, but it has the better maybe the instruction tuning stage. So that is more high quality data, right? So here we actually, for the pre-training, we have large scale noisy data, but for the fine tuning, we have the ground truth label, the annotation from the clinicians. So those data are actually very clean. So then this still sort of like making we have a strong model where we have a very noisy pre-training stage, but we have very high quality data for our fine tuning stages.
Thank you, Hanwen.
Yeah.
And sorry, just a quick question. Based on the presentation here, I assume the slides were not only H&E, you had IHC as well?
Yes.
Okay, cool. Thank you.
Yeah, so actually not HNE, HC and other kinds of probably channels. So we didn't exclude this because in our experiments we found that if we keep increasing the number of the images we have been using in the pre-training stages, we can increase the performance. So I don't know if I have the slides in this presentation, but I can talk about a little bit maybe after this presentation, like the early hints of the scaling law when we pre-train the large scale models. Yeah. Yeah, so maybe let's talk about that later.
Sure, yeah.
Yeah. Yeah, so any other question?
No, I
Okay,
think we're
cool.
good, thank you.
Okay, yeah. Yeah, so this radar plot summarize the performances, the improvement of performance of our model compared to other state-of-the-art baselines. So here we evaluate our model across 26 tasks, including the cancer subtyping task and also the pathomics tasks. So actually, if our model has been pre-trained on very large scale data, we argue that this model can potentially gain the capability to do lots of tasks. And if those tasks are really diverse, it covers maybe the histological type prediction, the biomarker prediction, and also others like the staging predictions. Then this model potentially have the capability to follow the cancer guidelines. And after we have those set of fine-tuned models, then we can see that the GigaPath can be the model, first vision model to follow the cancer guideline to give the treatment option. So here we so think about the cancer guideline. So then we evaluate our model on the histological type prediction and also the biomarker prediction and also potentially the staging prediction problem. So let's start from the cancer subtyping. So basically here we evaluate on 9 different cancer types. So we observe significant improvement here on 6 cancer types. And one great example here is the ovarian cancer in the figure A. So ovarian cancer here basically including 6 different cancer subtypes, but we still observe that our model achieves better ALC greater than 0.9. So we think that this is exciting. And also we feel like because of most of the cancer subtypes actually rely on the tail level features, and this is not like this is more like evaluating the efficiency of the smaller segments of the learned model or the local features of the local feature extractors. So we hope to have tasks that is more like emphasizing on the slide level features or the global patterns. So next, we try to apply this model to biomarker predictions, which is also usually the second step in the cancer guideline. As you can see that in the cancer guideline, we first determine the cancer subtype, then we check the biomarker results, then we can drop into other pages to check for the treatment. So for the biomarker predictions here, we evaluate mainly in 2 settings. The first setting is very challenging. It's the pan-cancer 18 biomarker predictions. So 18 biomarkers including some common biomarkers like the KRAS, EGFR, TP53, those oncogenes, but also it includes other biomarker, all the cancer genes that is not so common in our database, like the PIK3CA, KMT2A, those kind of thing. So from the performance, we found that we actually gained the SOTA performance on 16 tasks. with significant improvement, statistical significant improvements on 12 tasks. And also we found that because actually we didn't do the cherry picking here, cherry picking mainly refers to that the cancer pairs and also the oncogenes, as we already know that for certain pairs, let's say the lung cancer and also the EGFR, we know that many models can have a really good performance on these specific tasks because it has been shown that for the lung cancer, maybe specifically the lower cancer, EGFR can be more easily predicted by the models. But actually here we didn't do the cherry picking. We try to evaluate our model in the most challenging setting. So, and also actually indeed for some tasks, even the world-class pathologists have no idea where the signal is. So taking everything together, we can see that our model gained a super performance, but to be honest, on certain tasks, it's still not that great because we actually the setting is too challenging. But we can also think that our model can actually be used as the tool to detect the pairs between cancer types and also the biomarkers that is unknown to the pathologist, and potentially because our model is an image model, we can try to identify certain image patterns on the host images. And if that certain patterns is closely associated with the biomarkers, then biomarker genes, then that can be used as image level biomarkers for the diagnosis. So that's the gene mutation prediction task. So one use case of this gene mutation task is the oncotype DX prediction. So oncotype DX is actually a score to estimate the recurrence risks of the patient. So actually, traditionally, this score was calculated based on 21 genes, so basically biomarkers. So if our model can really be good at predicting the biomarkers compared to other models, then we can think that if GigaPath is really good at predicting the oncotype DX score. So actually, we are trying to evaluate our model currently, and we collected a lot of data from the Providence, and this work is still in progress. But we have seen some early hints that our model can predict the oncotype DX score. So this is one use case of the biomarker prediction task. So the third task is actually the slide level vision language pre-training. So this is actually we're trying to map the whole slide images into the text domain. So this is aligned with our previous goal, where we have maybe the rare paired image modalities, and we in those cases we try to use the text as bridges to connect almost every kind of image modalities together. So here in the pathology cases, specifically it's the slide level vision language pre-training. So actually, lots of models have been proposed before our work, like the Biomarker Leap, MI0, and PLEAP, and those papers are all published at very high-profile journals or top conferences. But those for those models, they are all the patch-level models actually. So patch-level models means that when we train the model, this model relies on the paired data between the images and the languages at the patch level. So those models are either trained from maybe the image caption pairs from the literature or the image caption pairs from the Twitter, from the social media. So actually those resources are very, not that prevalent. So actually those data are also very expensive to get. Like the Biomarker Leap, the pre-training data is actually from the 15 million scientific literature, and that is a pretty large scale. But actually, if we think about the whole slide image or the pathology cases, actually for each pathology images or for a set of images, we have the pathology reports naturally. So that's kind of another format of the language here, right? So this got us thinking that can we directly use the pathology report to align our model with it? Then we can directly translate one image modality directly to the pathology report. So here we did some preliminary exploration using the CLIP model. So it's still CLIP model, but different from the Biomarker CLIP. Our CLIP is at the slide level. So that's a key difference. And also for the pathology reports, because it's real world data, it has a lot of information like the patient metadata information. or the location of the cancer centers or the hospitals, and we think those information are not relevant for the diagnosis or the prognosis tasks of the model. So we use GPT model to do the pre-processing to sort of like cleaning the reports. And after we get the clean report, usually consists of the diagnosis information or the findings by the clinicians, then we do the clip alignment, which is basically contrastive loss. And finally, we evaluate our model. We can compare our model to the Biomarker clip model, PLIP model, and MI0, and those are the patch level models. And we evaluate on the zero-shot cancer subtyping tasks and also the zero-shot mutation prediction tasks. So actually, our model are the first to evaluate on the zero-shot mutation tasks. As you can see that this task is pretty challenging. Even if it's for the supervised setting, it's already very challenging. But actually here we are trying to extend it to the zero-shot setting cases. And here we still observe that our model achieves total performance on the zero-shot, both the zero-shot cancer subtyping task and also gene mutation prediction task. And we argue that if we have this model, this nice model, then we can map the, at least in the pathology domain, we can map the host images into the text space. Yeah, so any questions so far?
No, I don't think so. Thank you.
Okay, great. Yeah, so this is actually the scaling law I have talked before. So here we try to freeze, so we do the experiments from 2 dimensions. So first case is that we try to freeze the size of the data set, and we increase the model size a little bit from 23 million parameters into 1 billion parameters. And we found that the AURC of the mutation prediction task keeps increasing. And also, as you also see that the AURC is not so high because, like what I have talked before, this task is pretty challenging. But we can still see like if we keep increasing the size of the model, the AURC keeps increasing. So this is one hint that maybe in the future we can think about training a larger model. Even though our model has already been the largest model, but if we still keep increasing the size of the model, if we keep using more parameters, perhaps we can even get a higher AURC, maybe a 70 something. If that's the case, then it will be really exciting. Another dimension of the experiment is like we freeze the size of the model, but we increase the size of the data. So we try to downsample the data a little bit. We downsample the 1.3 billion images. That is all the data we have. All the pre-training data we have, we sample it to 50 million. And then we increase from 50 million to 500 million until the whole data set of what we have. And we still observe that the AURC keeps increasing from 61 to 67. So maybe in the future, we can also think about like collecting more data, and then we will be having a stronger model. So that's just some early hints from our preliminary experiments. So maybe this give us idea like in the next step, if we don't have a better model architecture, or we don't have maybe more or higher quality pre-trained data, we just keep increasing the size of the data or the size of the models. We can also like have better models. So there are still improvements for the model. Please.
Yes. So just a quick question, more of an idea really. Do you know, have you had this experience, or do you know if anyone has done it, that during the pre-training, because you're using like knowledge distillation methods for pre-training, right?
Yeah.
Wouldn't it be possible that for the teacher model, you use the largest model that you can, like VIT Giant, and the student model that we end up using later on, you just use a smaller one, like VIT small. How would that affect the results? Has anyone tested this? Have you looked into that?
Yeah, that's a really good question. So actually, if we check the original Dano paper, so the Dano V2 model is actually originally trained on the VIT giant model. Then it used the knowledge distillation to have a set of smaller models. And if you check the performance of the smaller model, it's very interesting that the smaller model have a very close performance to the VIT giant model. So actually, we are also working along this direction to directly, because Dano V2, the model architecture already is a distillation architecture. So we can directly use this pipeline to distill our VIT giant model into a set of smaller models. And that smaller models, if it has a closer or similar performance, that's pretty exciting. That means actually we can have a pretty small model, and that can be run on single GPU devices. And many clinicians or doctors can run this model locally, even with a CPU machine. So that will be very exciting, and we're actually working along this direction. And yes, but also I also want to emphasize or highlight here is that in order to get those smaller models, we needed to train a large model first. So here our experiment here is basically on the maybe the first training stage, like the first model we have.
I see. Okay,
Yeah.
makes sense.
Yeah, thank you.
Looking forward to seeing those models coming out too.
Yeah. Yeah, so maybe I will quickly go over the remaining slides as we are running out of time. So we also try to apply this model to do like the vision language model. We use the lava recipe to make the model a chatbot, and after we get this chatbot, it can interact with the clinicians, and this is maybe a more user-friendly interface. Interact with people, with clinicians. So we do some VQA tasks here. So those are also the preliminary results. We compare to the GPT-4 vision model and also the other medical models like the LavaMed models. And we observe that our model has a better performance, even though we have very limited instruction tuning data. So we attribute this to the strong quality of our vision encoder of our vision foundation model. So this is actually another hint for us, because as we can imagine that in the medical domain, the paired data or the instruction tuning data is very challenging to have. So in that case, even if we don't have very large scale instruction tuning data, we can still keep improving the quality of the vision encoder, and that can still give us a very good performance improvement on the VQA tasks. So that's some early hint I would like to share here. And also, I will quickly go over other framework we developed to address the real paired modalities in the medical domain. So this model is a well-translated model. So the basic idea is that we use text as the bridge to link all the modalities. So one example here may be like, for example, if we think of one person travel around the world, this person only knows one language. Then if it goes into other countries, maybe there will be problems due to the languages. But if there is a world language, then every people in different countries talk using the same language. Then for the people who are going to travel, these people do not need to learn every kind of languages. He only needs to translate his language into the world language, and that world language will be the bridge to connect the world, to connect all the languages in the world. So the same cases here, we are trying to use the text as the world languages to connect all kinds of image modalities or other modalities in the biomedical domain. So here we propose the biotranslator, which is translating all kinds of biomedical modalities into text. So here we investigate mainly four modalities, the drugs, which is the molecules, and also the genes, phenotypes, and also the pathways. So different data with different structures, but we translated them into the text space. So our performance is summarized here. So the red line here is the supervised baseline. The supervised baseline is trained on the paired data. So we have some paired data, but those paired data is never seen for our translation framework. But if we look at the ratio of the training, so ratio of the training sorry, I'm wrong here. So the red line is actually our work, and also other lines is the supervised baseline. So for the supervised baselines, we found that if we improve the ratio of the training data, the performance of the baseline keeps improving, and sometimes it's better than our model. But we argue that if it's the real data setting, like we only have a partial of the training data, and especially for many of the data, we don't have the pairs, then the performance of the model will purely random. But if we use the text as a bridge, we can still understand the correlation between different modalities. And that also enables our model to capture or to do the zero-shot classification, even though we never see any paired data between different kinds of modalities. So those are also like a idea from us, like how we handle the missing modalities. So maybe in the future, if after we replicate GigaPath to all the image modalities we have, then finally we can have the biotranslator, right? We translate all the foundation models to text-based, then we link everything together. Then that will be a medical version GPT model. And that can help us to have the comprehensive patient-level representations for better clinical outcomes. So yeah, so actually that's the end of my talk. So here's the link to our model and our paper, and we are very excited that this work can be published in Nature. But we also hope to emphasize that this is just maybe a very baby step for us in this whole journey. Like we only started from the pathology modalities, and we also very excited for the following up work to replicate to other image modalities and potentially have a patient level representation models. And also we welcome everyone interested in our model to download the model, and also open the GitHub issues if you encounter any problems, or directly email me if you have any issues when using our model. Yeah, so I think that's the end of the talk. And also let's see if our friends have further questions.
Well, thank you very much, Hanwen, for a really, really fantastic talk, and yeah, great work that you've done here. I mean, in our lab, and thank you as well for also sharing this model online. In our lab, we're already starting to use this in our work. So that's amazing. So yeah, so we'll open the floor to questions. Does anyone either in person or online have any questions they'd like to ask? We've only got a minute or two left or so before we need to draw the seminar to a close. But we have got time for maybe one or two questions.
Yeah, I just wanted to say thanks as well. Just a quick question, if I may again. But
Please go for it, Mr.
but Adam, if anyone in the room has a question, let them ask the question first because we are limited in time.
I think you can go for it, Mr.
Okay. So my question was, have you tried, or has anyone tried that use the long nets, the slide level network with feature encodings coming from other feature extractors rather than the one that you've proposed? How would it work to use other feature extractors, in other words?
Yeah, so specifically you mean the Dino model here, the tau encoder?
Yes.
Yeah. So actually, I don't see other work is exploring other options because so actually we have specific thinking here. So for the Dino model, a nice property associated with this Dino model is that Dino model tends to learn an embedding that has a very good linear probing performance. So linear probing performance, good linear probing performance means that after we finish the inference, we can basically just save the embeddings into the disk, and we don't need to fine tune the Dino model in the future, and we can still get a similar good performance. But if we are using other kinds of like tau encoders, maybe the mask autoencoder and other mask modeling approaches, then those models actually heavily rely on fine-tuning the model to have a good performance. So that means that if you use those models as the feature extractor, you need to have an end-to-end fine-tuning approach in every kind of task. So that's end-to-end fine-tuning is extremely expensive. And I don't think currently any algorithm can handle the very heavy memory cost here. So that's why almost all the studies in this domain actually finally converged on the Dino approaches. So linear probing is the case. Saving everything into the embeddings locally saves a lot of time and also the cost.
Yeah, it makes sense. Lots of research have shown that having more strong feature representation matters more than the way you aggregate them. But thank you very much for the great talk. Really enjoyed it, and it had cleared up lots of things for me since I read your paper. So thank you.
Thank you for all the good questions.
Yeah, thank you very much, Hanwen. That's been a really, really fantastic talk, and we really appreciate you taking the time to give that talk at 6 a.m. on the day of NeurIPS. So, and yeah, best of luck with the future work. So I think with that, we'll draw this seminar to a close. But just a bit of a reminder for everyone else online in person, our next seminar won't be until after the Christmas break. It'll be on Tuesday, the 7th of January at 10 a.m., where we'll be joined in person by Professor Azra Raza from Columbia University in New York. So I hope to see you all there. But thanks again, Hanwen, for a really great talk, and I hope you enjoy Neurix.
Thank you.